This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Thank you very much for inviting me to speak to you today. I'm going to be talking mainly about 3 studies, and the reason I've chosen these 3 studies is they show changes with caseload mix over time. Now the 2 buttons, do I get it right? I did. First up, I'd like to say the ICU liaison role, even though it's been around for quite a while, since 1998, it's still a relatively new clinical service role. And the understanding of the role is very limited, including within my own hospital. A lot about the ICU liaison nurse role is unknown. We don't know how many services actually have this role. We don't know what the demand for the service is. And we don't really know what the scope of practice of the service is, or the type of patients they review. What are the characteristics of the patients? Why were they reviewed? What were the interventions performed by the team members, and what were the outcomes? The first study that I'd like to talk about is a single-site study by McIntyre and colleagues, and it looks at the evolution of the role in one site, and they report on the epidemiology of patients reviewed, the characteristics, the interventions, and the outcomes. It's a retrospective observational study from September 2007 to December 2009. They collected data on the patient demographics, the referral source, the variables to quantify illness severity, patient at risk score. This is a really interesting tool. It's an objective scoring tool, and it allows them to look at the vital signs at the time of discharge from ICU to determine if they require ICU liaison follow-up when transferred to the ward. And they also looked at in-hospital mortality. The hospital has a 400-bed hospital with a 19-bed ICU with approximately 2,200 ICU admissions per year. They also have a 3-tier rapid outreach. They have the Respond Blue, medical emergency team, and the ICU liaison nurse team. The results: there was over 3,000 patients reviewed, and 73% were post-ICU. Remember that number. 27% were non-ICU, 19% were following a MET review, and there was 8% de novo referral. Mortality was high for the non-ICU group at 18%, compared to post-ICU at 6.5%. The overall mortality of the patients they reviewed was 8.9%, and the most common intervention is fluid and electrolyte management, and there's a poster out there that also shows that that is the common medication for prescribing of the MET teams. The other thing they showed and highlight, which again I think is really important for these services, is they must evolve from when they commenced. They actually allowed these staff to have an administration day. Really important to be able to collect data, to provide the education, and to do the research. They also implemented the patient at risk scoring tool. And the other vital thing I believe they've done is they had a 6-month rotation position, which allowed ICU nurses to rotate into the ICU liaison role and actually get out and see what's happening on the wards. It also breaks down the silos and makes it much easier when they're trying to discharge patients if they actually know who they're talking to and what the skill mix is and what sort of cohort of patients they have on the wards. The second study is a multi-site study, and this is undertaken by the Australian ICU Liaison Nurse Forum investigators, and they attempted to identify how many hospitals have an ICU liaison nurse service. They looked at the documentation of timing of introduction of these services, changing caseload since introduction, and the number of annual patient reviews based on source of referral. It's a retrospective observational study. for 17 sites, 14 of which were from Victoria and 3 from New South Wales. Each site had to obtain ethics approval. Data was collected on the time of service implementation, number of EFT positions each year, number of patients reviewed, and who were discharged from ICU, seen during or after a rapid response team review or de novo referrals from the ward. What we noted is there was quite considerable variation with each of these sites, from number of hospital beds from 77 to 475, from annual hospital admissions from just over 5,000 to 83,000, and the number of ICU admissions from 400 to 2,000. This looks at the uptake of ICU liaison nurse services per year, and you can see that they've been around since 1998. The majority of services increased following 2004, and that really coincides with the substantial funding commitment within Victoria. And since this study had a large proportion of Victorian hospitals, you can see that trend. And there's also a huge increase between the 2004 and 2007 period. Looking at the number of patient reviews by referral source, the total referrals were for 123,000 patients. For ICU referral, we're down to 59.3%. If you remember, it was 73% for the single site study. For rapid response team referral, 21%, and for de novo referral, 19%. I have to put this slide in. In 14 of the sites, the monthly number of patients reviews increased by median by 54.3%. Many of these sites did not have increased EFT. So I think, like the Met services, we're struggling to keep up with the workload. This latest study, which is currently, hopefully will be published soon, it looks at the epidemiology of patients reviewed by the ICU Liaison Service in Australia, and it's a prospective multi-site study. This is also undertaken by the Australian ICU Liaison Nurse Forum investigators, and I'd also like to acknowledge the Intensive Care Foundation, who did provide funding for this project. The aims of the study was to assess the characteristics of the patient screened, number and source of referrals, number of reviews for each patient, baseline characteristics, interventions received compared to those who did not receive interventions, patient outcomes and discharge destinations. It was a 2-month prospective observational study of 20 sites. We would have liked this to have been longer study period, but we didn't want to cause burnout for the ICU liaison nurses who are undertaking this on top of their normal workload. 13 sites were from Victoria, 3 sites from New South Wales, 2 sites from Tassie, 1 site from Queensland and 1 site from Northern Territory. Each site had to again obtain ethics approval. We had a management and writing committee that developed the protocol, paper-based scannable case report form, data dictionary, and expressions of interest were obtained and investigator protocol agreements signed. Again, considerable variation in the hospitals and with the practice. So not only with the hospital beds again and hospital admissions, but also with the number of ICU beds, number of ICU admissions, and the number of patients the staff actually, the ICU liaison team actually reviewed from 48 to 447, and the review episodes from 94 to 1,100. The median duration of each review was 29 minutes for the first review, and that dropped down to 20 minutes for subsequent reviews. Reviews were less common after hours, and that might be partially explained because only 2 services ran a 24/7 service. This is a histogram showing the ICU liaison nurse review according to time of day, and not surprising, most of the reviews are occurring between 9 a.m. till 6 p.m, and that's usually the times they work as well. All right, so the number of patients screened in total for this study was 3,799, and there was 2 arms. The first arm had no interventions or subsequent reviews. The second arm, they had interventions performed, and it was either where they were reviewed once or they had multiple reviews. The overall mortality was 10.2%, so very similar to the first study. And the ones that had no intervention, the mortality was 4.6%, so again similar to the first study. The mortality increased significantly for those that were reviewed once, and we also found for that cohort, this is where a lot of the advanced care planning was being initiated. So these were often the end-of-life care patients, and 10.9% for those patients that required multiple reviews. The 5 most common reasons for referral were, again, follow-up after ICU discharge. So the first study reported 73%, the second study was 59%, and now we're down to 45%. So that's decreasing with time. Part of the rapid response team, 24%. Ward patient review meeting the worried criterion, 10.8%. Post-rapid response team review, 7.7%. And patients who meet physiological criteria, 4.9%. The patients who did not receive an intervention were younger, more likely surgical, and less likely seen during or following a rapid response team. This is the interventions performed during the ICU LN review. Non-medication therapy was very, very common. Diagnostic testing, providing medication initiation, referrals, and treatment limitations. And the treatment limitations was 12.8% in the group that were only reviewed once with interventions. We also did a multiple variable logistic regression analysis to determine the predictors of in-hospital mortality for patients reviewed by the ICU liaison nurse service, and we found that blood pressure, respiratory rate, saturation on initial review were causes, age, altered conscious state and comorbidities, and I think that's very similar to what we've heard over the last 2 days. These services provide a safety net for ward patients. The majority of patients reviewed are follow-up from ICU or in the context of a rapid response team call. They're effective in screening which patients require ongoing review. They do participate in end-of-life care, limited hours of coverage, only 2 operated 24-hour service. We're not sure of the exact skill set required for follow-up of patients versus rapid response team. These may be different. And these nurses seem to be working more at an independent practice and maybe at the nurse practitioner level. So there's some work there to be done with the educational requirements. These studies cannot be undertaken without the buy-in from all of these people that are listed up here. They are all the investigators at each of the sites, and my deepest gratitude goes out to them because it was a very extensive study, and I really do value their contribution with this study. Thank you.